This morning, I'm really excited to introduce our speaker, Dr. Jenni Villavicencio. She completed her master's in public policy at the University of Michigan, where she also completed her fellowship in complex family planning, and her residency in obstetrics and gynecology at Women and Infants Hospital in Rhode Island. She serves as the Director of Public Affairs and Advocacy at the Society of Family Planning, and previously was the lead for equity transformation at the American College of Obstetrics and Gynecology, where she has led the college's equity, diversity, and anti-racism work. So we're really excited to have her as a leading voice this morning to get to talk to us.
Thank you so much. Good morning, everyone. I hope it's not too cold where you are. I might make you jealous in DC. We got our first little flurries yesterday, but I'm really excited to be here with you this morning and to talk about a tough, kind of heavy subject, but hopefully we'll be able to work through it together. We're going to be talking today about challenging racism and how to question power in leadership. Some of you may have seen a version of this presentation at CREOG. And I'm really excited to be bringing this to academic institutions in a way, thinking about how we can challenge some of the hierarchy and the power that we know to exist in academic institutions. So thank you so much for bringing me in this morning. I have no financial disclosures. Let me see if I can get this to move forward here. I have no financial disclosures. As you just heard, I'm the Senior Director of Public Affairs and Advocacy at the Society of Family Planning. And 6 months ago, I left the ACOG, where I had been serving as the lead for equity transformation, leading their anti-racism work. The other disclosure that I always like to talk about here, especially when speaking about racism, is that I humbly learn and grow from colleagues and scholars of color, and in particular, Black feminists, and am always deferent to their scholarship. And sorry, my dog is interested in this presentation this morning, apparently. Always deferring to their expertise. So our objectives this morning are to understand the historical and current conditions that necessitate frameworks such as reproductive justice and anti-racism, recognize the role and power dynamics play in anti-racism and our practice of anti-racism, and identify areas in your work that could benefit from the application of racism. So I'd like to start by discussing what I think is one of the critical components to receiving and learning about new frameworks and ways of seeing things, and that's to examine our place in the world. One way to do this is to think about our positionality. And positionality is defined as the social, political context that creates your identity in terms of race, class, gender, sexuality, ability status, and other identifiers. Positionality also describes how your identity and identities influences and potentially biases your understanding of and outlook on the world. Thinking about positionality, about our potential inherent setbacks and head starts in life, takes humility and it takes vulnerability. And it often requires that you look at yourself objectively from an outside lens, which can be pretty challenging. So I start off every talk that I do, whether it's about racism or abortion or any of the other subjects that I talk about, I do a personal disclosure of sorts of my positionality to the subject matter that I'm presenting on. But not only does this require me to keep my positionality in mind while I'm preparing the talk and thinking about my biases to the subject, but it also reminds me to remain vulnerable and open to the ways in which my identities, many of which I celebrate, interact with my work and potentially bias me. So my positionalities to this talk in particular are that I'm a Cuban American, I'm first generation Latina, but I exist in the world as a white woman. I am white passing, and my mother is white. I am the daughter and wife of political refugees, but I am a natural born US citizen. I had a supportive, financially stable childhood with married parents. Both of those parents are now ill and live with me in my home. I am cisgendered, heterosexual, and partnered. I've never been pregnant. And as you heard, I'm an OBGYN and complex family planning specialist, which means I provide abortion care. And I led anti-racism programming for ACOG that was bolstered by formal graduate education. So I want you to take a moment and think of your positions, in particular, those that pertain to your work. I would like it if you would try not to think about what they mean. Don't judge them. Just take stock. Return to them often, those positionalities, as we move through this talk, and use them as a way to absorb and reflect on the information you're receiving, and perhaps some of the feelings that you may be feeling about the information or concepts that you're receiving. In their book, Reproductive Justice, Loretta Ross and Ricky Solinger explain that the reproductive justice framework derives its vital depth from drawing attention to the persistence of history, and in particular, the injustices that penetrate and misshape current systems that impact all individuals. History is a critical aspect of reproductive justice because, as William Faulkner put it, the past is never dead. It's not even the past. Anyone who's seen me speak before knows that I really love this quote because I think it's so simple and really brings to the forefront and counters a lot of the arguments that we hear against practicing anti-racism. The past is never dead, and it's not even the past. History can better help us understand our patients' experiences with the medical system, as well as our roles as physicians. So we can't talk about racism without addressing the devastatingly unjust history of medicine, and specifically our field of OBGYN in the United States. By now, I hope that you have heard about this infamous gynecologist, J. Marion Sims. His forced and non-consensual experimentation on enslaved Black women, such as Betsy, Lucy, and Anarcha, gave rise to many techniques that we use in GYN surgery today, techniques that greatly improve the lives of many of the people that we operate on. J. Marion Sims is but one example of how the reproductive capacity of enslaved Black women were utilized and traded as economic capital just a little over 100 years ago. Also an excellent example of how something good, techniques for vescovaginal fistula repair, can come out of something incredibly horrifying. At the same time that the cruel slavery regime was passing policy and supporting practices to ensure that the population of enslaved Black individuals that formed the backbone of the American economy continued to grow, the US government pursued anti-natalist programs to reduce Native and Indigenous populations. The military was employed to, the US military was employed to force Indigenous communities from their land and relocate children to more quote unquote suitable Christian households, and thereby destroying Indigenous families and communities and ensuring that the long-held values of motherhood and family were only applicable and available to those who were white and with means. And as the brutal 19th century rushed on, the Industrial Revolution ushered in a population boom, and along with it, the eugenics movement, with state-led efforts to quote unquote improve the genetic quality of the human population through promotion of sexual reproduction for people with quote unquote desired traits, and reduction of sexual reproduction for people with less desirable traits. A landmark Supreme Court case, Buck v. Bell, with the two women pictured down below here, tackled the question of this state-sanctioned sterilization. Carrie and Emma Buck were a mother and daughter who were sterilized in the 1920s by the state of Virginia without their full consent. And they were sterilized by the state for feeble-mindedness and promiscuity. That's an exact quote. Ultimately, 32 states passed similar laws related to the state's right to sterilize a citizen. And the right of the state to make these decisions was upheld in the court case Buck v. Bell by the Supreme Court, and as of 2023 has not yet been overturned. And over time, Explicitly, eugenic policies waned, and the growing societal fears of overpopulation and welfare dependency took their place. These conjured theoretical specters ushered in a new era of government-supported involuntary sterilization based on the ideas of quote unquote fitness and contribution to society. These programs, probably unsurprisingly, were targeted at women of color and low-income women. It's estimated that during the 20th century, over 150,000 low-income women, women of color, immigrant women, and women with disabilities were sterilized without their knowledge or their consent. During the 1960s and 70s alone, nearly 1 in 3 Puerto Rican women and nearly 1 in 4 Native American women were forcibly or involuntarily sterilized, impacting entire generations to follow them. Another landmark case, Ralph v. Weinberger, was a 1970s case that involved 2 sisters, Minnie 12 and Mary Alice 14, who are pictured here, who were sterilized after their mother, who was unable to read, signed what she thought was a consent for birth control with just the mark of an X. They were sterilized against their mother's will. This landmark case ultimately led to the development of the informed consent, the concept of informed consent, and laid the foundation for the federally mandated Medicaid sterilization consent form that we all in OBGYN really kind of struggle with and see as a barrier. This is where it came from. Mary Alice and Minnie just spoke last year, or actually rather, it's December, February 2023 at the Betsy and Arca and Lucy conference in Montgomery, Alabama. These women are still dealing with the trauma and tragedy of their state-sanctioned sterilization. And at the time that coercive control of reproduction was being carried out by doctors, doctors and other healthcare professionals were acting as agents of the state. And additionally, modern medical technology was being developed through the exploitation of poor people of color. We hopefully are all familiar with the absolute horrors of the Tuskegee trials, but perhaps not as familiar maybe with Henrietta Lacks, whose devastating cancer diagnosis and death led to the theft and exploitation of her tissue, resulting in our modern medical miracles that we now depend on. That's the reason why you have that line in every consent form about medical tissue donation. In a lot of ways, it's because of Henrietta. The birth control pill that we all know and love was developed through contraceptive trials in Puerto Rico, testing pills first on rabbits and then immediately on women on the island, who were often unclear that they were participating in research, let alone one that could impact their ability to get pregnant. These events are but a fraction of the historical injustices perpetuated on poor women of color throughout our history. And the past is never the past, because we are still seeing coercive control of reproduction of those that we see unfit. California and Tennessee all have looked at sterilizations of female inmates that are incarcerated. And some of those states have banned sterilizations because some of them are being performed in exchange for lowered sentences, a very clearly coercive situation. Racist policies yield racist results. And so it's not only in medicine, but we end up seeing the results of it in medicine. For decades, starting at least in the 1930s, low-income and minority communities were intentionally cut off from housing lending. This is called redlining. It was an entire system. To the US government, it was a racially discriminatory grading of neighborhoods for mortgage credit worthiness. It's a little bit technical, but essentially they were redlining areas and labeling them as hazardous, not hazardous to health or hazardous to safety, but hazardous to investment. And they implemented a federally sponsored Homeowners Loan Corporation, HOLC. And they were color-coded maps, one that you can see here. And they were basically to remove people of color and to ensure that communities stayed white. we are seeing this tool of structural racism influence and how it has influenced the trajectory of neighborhood and social material conditions. Because if you take those old redlining maps where people were completely actually barred from being able to invest and buy homes in neighborhoods, those maps through research basically map almost perfectly with maps of preterm birth, with higher maternal morbidity and mortality. There have been really intense looks into these maps in California and in New York. And we see that these maps are associated with increased experiencing of severe maternal morbidity, especially among Black and Hispanic birthing people, both in California and New York. And so we know that it's not just in medicine, but something that happened nearly 100 years ago is still impacting almost directly how our patients come to us. And so I want to pause here for a pulse check. It's really early in the morning. And so I want you to take a moment to sit back and reflect after hearing some of the legacy of our beloved profession, and also about how historical policies that you may not even have heard of or knew much about are impacting your daily practice of medicine. How are you feeling? Right now, are you feeling shocked, upset, numb, defensive, bored, uncomfortable? Your reactions are yours. Feel them, sit with them, and then, much like the positionalities that we talked about earlier, don't judge them. Rather, use them during the rest of this presentation as you move throughout the day and the rest of the week as a pathway to a little bit of self-excavation into those feelings and into these concepts. So I want to move now into the concept of anti-racism and what it is exactly. It seems like it's self-explanatory from the word itself, but there is a lot of nuance to it, which I think is really critical and important. So many of us may have been taught or kind of understood internally that the opposite of racist is not racist. But in fact, the opposite of racist is not racist, according to the framework of anti-racism. Anti-racism is actually the practice of actively identifying and opposing racism. The goal of anti-racism is to actively change policies, behaviors, and beliefs that perpetuate racist ideas and actions. So if you think about this with an analogy in health, for example, if you are unhealthy, the opposite of unhealthy is not just being not unhealthy, right? You have to practice being healthy. You have to exercise. You have to practice that. You have to practice all of the behaviors that we know that lead to a more healthy life. It is a daily decision and daily action. And because racism itself is an action, the antidote is not merely a state of being not racist, just existing and saying, I'm not racist. But the antidote to racism is, in fact, the countering action of anti-racism, a practice. A tool, I'll be bringing you a few tools in this next section of the talk. And one of the tools that I think is really important and helped me along my anti-racism journey is recognizing and understanding and internalizing that racist is not an identity. It's unfortunately in the political sphere, in media, and sometimes in interpersonal relationships thrown around as an identifier. You are racist, that person is racist, but it is in fact not an identity. Not like those identities that I shared earlier, the ones that you thought about. Racist is a descriptor, it's an adjective. And the same goes for anti-racist. And so instead of me identifying as an anti-racist, I identify as someone who works to practice anti-racism. It is a concept as well as an adjective and a descriptor. One concept that I find really, really helpful, especially when I'm having a challenging day, is one that was introduced by Ibram X. Kendi, who is a scholar in anti-racism. And it's this idea that every single minute of the day is an opportunity to be either racist or anti-racist. And each of those minutes will be described as racist or anti-racist. And so that means that 1 minute I may be doing something racist. I may be acting in a racist way. And then the next minute I may be acting in an anti-racist way. And that is the result of living and working in a system and in a country that we just learned is steeped in white supremacy and racism. And it doesn't necessarily mean anything about me as a person, whether I'm a good person or a bad person. What it does mean is that if I'm practicing anti-racism, need to work to make as many minutes in my day as possible anti-racist minutes, acknowledging that some of those minutes are going to be racist, and then working to make the vast majority of them anti-racist. To me, this was a very relieving and kind of freeing tool and concept, because if I did something, I knew that I perpetuated harm, but that I could move to that kind of next moment and work to never perpetuate that harm ever again, and make sure that my next several minutes were anti-racist. A final quote on this subject from Ibram X. Kendi is that what we say about race, what we do about race in each moment determines what, not who we are. I think that these are really important tools and really important concepts, because one of the challenges to engaging in anti-racism that I have found, especially from people who are either white or white passing, who are really interested in engaging in this, they're afraid of messing up. They're afraid of doing the wrong thing. And some of that is concern for causing harm, which I think is really critically important that we think about. But a lot of it is based in ego, is based in us not wanting to feel like we're bad people, us not wanting to feel like someone is going to tell us that we did something wrong or criticize us. And it makes us cower and step back and not want to enter into it. And so for me, someone who is very, very perceptive and sensitive to kind of the external view of myself, this was extremely helpful to know that it doesn't say who I am. It just is speaking to what I am. And then ultimately I can learn and move and change and work within my values. Another concept that I think is really important that follows along with that is that when we are working, particularly institutions and systems, let's say academic medicine, we oftentimes focus on the myopic. We look at the crowd of people that we're around and say, oh, that person is racist, or that person is acting in a racist way. And we kind of point people out and we label them and we put them in spaces. And that can be a really important tool, especially for people of color who are experiencing racism on a regular basis. But it misses the larger picture of the system that exists that we are in. So your institution, your department, your entire university is a system. And while there are individual actors within that system who may be acting in a racist manner on a regular basis, or hold racist beliefs, or upholding racist policies, we really need to consider how the entire system is influenced, and that even if there are many people in that system who are not regularly acting in an overtly racist way, they are still part of a system that is influenced by history, is influenced by power and the maintenance of power, and is influenced by those policies and structures that are put in place. And so in order to practice anti-racism and really make a difference, we have to focus on power and policies, not just on people. That's not to say that we don't focus on people and on individuals' behaviors, but if we don't zoom out and look at the entire system and on the power and policies that are persisting the greater harm and oppression, we will never achieve anti-racism. And I would argue that the individual focus, specifically by leadership and people in power, is missing the mark in terms of really practicing anti-racism institutionally. I really love this image about the wheel of power and privilege. It is a step up from thinking about your positionalities. Now you map your positionalities on this wheel of power and privilege. The center is where there is the most power. And so you map yourself along this wheel. Some of your identities may be far away from power, and some of them may be really close. But this helps, and I think is a kind of objective way to look at your identities and see how close you feel to power, or that you are to power, excuse me. You may not feel that close to power, but you are actually in society that close to power. And so as we do this, and we think about how much power we hold as we move in the world, one really important thing to remember is that probably the most powerful thing that we all have in common is the fact that we wear this white coat, theoretically, and that we carry this degree, and that we have an expertise that the vast majority of the population does not. The amount of power and proximity to power that this confers us is enormous, and must be challenged on a regular basis with really intense intention in order to mitigate the harm and prevent harm that can come from the power that exists with just us existing as physicians. So I want to pause again here. This is a lot to take in. And for this pause, I want you to think about a patient encounter that you've had at some point in your career that you felt was unjust. And then I want you to think about why it was unjust. What happened? And now I want you to think about what were the intersecting identities that perhaps contributed to that. Were there power dynamics between the patient and the system that made it worse? Maybe the patient and you that made it worse? And how does viewing the event through the framework of anti-racism change the way that you see that? Racism is about power and privilege, as we've discussed. It's about who has it, when, where, and how it is wielded. It is about the systems that were designed specifically to uphold that power, not people. Again, focusing on systems. And of course, systems and policies are made by people, but the sum of those parts oftentimes is much greater than the parts themselves. And so anti-racism is about disrupting existing power and privilege structures. And when we say disrupting, that can feel a little bit scary. And so we'll talk a little bit about what that might look like in our context. What does anti-racism look like in medical education, in clinical medicine? So I found this tool from a sociologist, Nikki Black. This is my kind of adapted version from her. She is an incredible scholar, and she suggests that, especially in the United States, that we, when thinking about certain actions or things, we replace racist or racism with harm or harmful. As we previously discussed, the terms racist and racism are steeped in fear and defensiveness, and they come with a whole lot of stuff, especially or in particular for people who are really trying to practice anti-racism. And so you can replace it, at least temporarily, with harm or harmful. So one example here is, this is an actual headline from the Columbus Dispatch that says an ex-employee says that Verizon Wireless tolerated racist behavior at a Lancaster store. So if you read this headline, I want you to be honest with yourself about how you may receive it. I know that sometimes when I'm not operating from my most elevated self, I read something like this and I'm like, well, what is racist behavior? Are they saying that, it was racist when it actually wasn't racist? This happens a lot in medicine. We hear about someone saying that they felt like they were harmed by racism in the system, and we're like, no, it's not racism. It's just that's just the way that medicine works. And so the suggestion is to replace this word racist with harm or harmful. So if we say ex-employee says Verizon Wireless tolerated harmful behavior at a Lancaster store, if that were the headline, how might you respond to that? Would you feel more open to that ex-employee's claim? Would you feel more open to a patient's claim that harm was perpetuated rather than racism? And so instead of asking, especially institutionally, when we're looking at our policies, is this policy, practice, or structure racist? Start by asking, is this policy, practice, or structure harmful, and to whom? This is a really helpful way to start a conversation, to remove a lot of the heaviness that term racist carries, and just get to the heart of what we're talking about. Who is this harming? We'll talk a little bit later. I'm going to do some self-disclosures about some of my learning journey. But for example, late policies. Are late policies racist? That's a really tough question, really sticky. And for a lot of us, especially people who have been in clinic and that last patient shows up 90 minutes late, where our knee-jerk reaction is to say, no, they're not racist. But then if we ask, are late policies harmful? And to whom are they harmful? It puts us in a different mindset. And then you ask why. Why are they harmful, and to whom? And this can be applied to yourself as well. When you're having a hard time in your practice of anti-racism and you're not sure if you're being racist, it may be easier to ask, am I being harmful? Is my action or my presence or my participation in this harmful? I want to be clear that this tool is not to erase racism or to say that the harm is not a result of racism. This is just the first step, especially for people who get a little bit tripped up on that term racist or racism. It can be really, really helpful to replace just initially for a psychological exercise. So let's ask some of these questions for academic medicine, anti-racism in academic medicine, and see if they ring a bell. So do students and trainees have access to anti-racism knowledge? Are we talking about systems? Are we talking about power? Are we talking about the history of racism in medicine with our students and with our trainees on a regular basis? Has a distinction between the goals of DEI, diversity, equity, and inclusion, and the action of anti-racism been made in programs and education? So diversity, equity, and inclusion are outcomes, right? How diverse are we? Is this an equitable policy, or are we operating equitably? How inclusive do we feel? Those are our goals theoretically. They really are a journey, but they are different. Just because you are working towards DEI does not mean that you're necessarily practicing and actioning within anti-racism. And has that distinction been made in programs and education? And how are you continuing to make that distinction? Are the concepts of power and privilege regularly discussed in curriculum, in training, in grand rounds, in M&Ms? And how are they being integrated into how we see patient interactions and patient outcomes? Oftentimes when I'm on rounds with some of my residents or students, I talk about what our power will look like when we move into the room. What does it feel like to be surrounded by a bunch of people standing over you with their scrubs on and with their beepers on and looking over at monitors, at the fetal monitor while you're talking to them? What does that power actually mean to the patient, and how do we mitigate that power? Maybe we can't mitigate it, but acknowledging that it's there is really important. Are current racial inequities being connected to both historical and current systems and structures? So as you look in your community and in your institution and at greater racial inequities at large, for example, maternal mortality, are those being connected on a regular basis in your institution to both historical, which is incredibly important, we know that from reproductive justice, and current systems and structures? Are we learning from that persistence of history and how it comes through? And are those that are explicitly in leadership as well as implicitly in leadership actively working to become anti-racist? What are the formal or kind of known pathways for those in leadership working to not only become anti-racist, but practice anti-racism? Those are some questions to think about for you and for your institution. And as you're doing that, I really strongly believe in showing and not just telling. So as we wind down towards the end of this talk, and you're thinking about your experiences with your patients in your institution, I want to share some of the learning that I have done as I've moved through my time as a physician and in my practice of anti-racism. These are mistakes and harm that I have perpetuated, mistakes that I've made, and then the changes that I've implemented as a result of a practice with both reproductive justice and anti-racism. And so when I reflect on my position as a physician, I visualize sort of this multiple floating connected elements that impact the way that I interact with patients in the world. This is not an exhaustive list by any means, but some of the most common and impactful elements include power, medicine, expertise, barriers, education, and history. And it's at the intersection of these and myself that so many of my misconceptions, false perceptions, biases, and learned behaviors arose, and that I needed to really focus in on to do the work. The first one you may have heard me talk about, you may have had your own experiences with this, and you are likely familiar with. As a family planner, I absolutely love birth control. I could talk about it all day long. And I particularly love LARCs. And I often joke that I love my IUD more than I love my husband. It's not true, at least not most days, it's not true. But in residency, I could often be heard saying outside a clinic room, damn, she picked pills instead of an IUD, because I felt that I had failed to get that patient to agree to the most effective type of birth control out there. I made judgments such as, man, she really does not need to be pregnant again after a particularly tough antepartum course, for example. And over time, with much reflection, learning, and really excellent patient mentors, I realized that this practice was frankly coercive. It was harmful. I, as a physician, had so much power in the room that I entered, as we discussed. And I was essentially the gatekeeper of the medical expertise that I had and the method of birth control that this person was seeking. I could wield that power to influence, to coerce. I read studies about how women of color felt uneasy when doctors suggested IUDs to them, and often felt that they were being coerced into receiving LARCs. And initially immediately felt defensive. I'm not forcing anyone to get anything. It's the most effective type of birth control. It's set it and forget it. The procedure is not that bad. Why wouldn't someone want the most effective type of birth control? I know I did, and I loved it. But then I realized, and I learned more about and reflected on the history of involuntary sterilization, of doctors lying to women that they felt really didn't need more children. And I realized that an IUD or an implant was as effective as sterilization, if not a little bit more, and required interfacing with the healthcare system again, another doctor or another provider to have that device removed. And it wasn't literally a lightning bolt for me, but there might as well have been. I practice now what I jokingly call lazy family planning. My only job in that room is to make sure that my patient feels supported, feels heard, and is getting the information that they want to receive from me, and to help them make the decision that they want to make. If they leave without birth control and they're a G10, P10, that's, as long as they feel well supported, heard, and got the information that they need, I feel like I have done my job. And I also take LARC counseling much more seriously, especially for people who are under-resourced, because so many people leave a clinic with an implant or an IUD and may not be able to have that received. And I have effectively sterilized them for the period up until the point in which they're able to get that removed. So after this realization, this was one of my first, I quickly became, and that was at the intersection of kind of my power and history. I became really uncomfortable with the power that I was wielding as a physician. And that doesn't mean that I quit or stopped being a doctor, but it meant that I used that discomfort in a way that, to improve the care that I was providing as a physician. And so at the intersection of power and the medicine that I was practicing, I really started to think about urine drug screening specifically. And I was given a speech by a NICU attending on the labor floor in front of all of the residents and all of the nurses. And this NICU attending gave a directive that said, drug test anyone who seems funny. That way we don't have to do it on the babies, just anyone who seems funny, order a UDS. And I realized in that moment that with one click of that box with that order, I could, and I have, changed the course of someone's entire experience of parenthood. I could and had changed whether or not the government, which we know from history has not, is often not fair or kind or just to under-resourced or people of color. I couldn't have changed whether or not the government became involved in someone's life, a system that was influenced by racism and stigma. So I made a decision that I am not an agent of the government or of the state, but I'm there to serve my patient. That is the oath that I took. And so I am extremely cautious about running a urine drug screen now, and I only do so if there's information that will directly inform my medical caregiving. I have a little bit of a reputation for arguing about these, either with NICU attendings or with nurses. In many of the hospitals I work with, it's part of the order set, and I save a different order set where it's unclicked, because I am not going to be responsible for a kind of flippant test, flippant ordering of a test that gives me actually really no clinical information that I need at all, that can have dire consequences for entire family structures and, based on evidence, generations to come. And then finally, the last one I want to talk about that's more recent for me is second stage decisions. So this lies at the intersection of the expertise that I have in medicine and the concept of expertise in general, and who has it. We've all experienced that second stage where she's been pushing for 3.5, 4 hours and it's not happening, and we're going to have to go for that dreaded second stage arrest section. And, we're talking to someone who's been working so hard to get the birth that they hoped for. And I had an experience with a woman, a Black woman, who straight up told me that she was terrified that she was going to die if she had a C-section. And I was really struck in that moment. It was in the middle of the night, and nothing that I was telling her about the statistics and the timing and all of those things. She was absolutely terrified of me and of that operating room. And she had a doula, and I have, really changed my thoughts and views and opinions and feelings on doulas and midwives, and all of the people who are much more able, time-wise, training-wise, expertise-wise, to support a patient. They have skills and expertise that I will never have to be able to support patients. And I remember turning to her doula and asking for help to help this patient make a decision that made sense for her and for her family. And ultimately, we were able to do the C-section. But this fear that came in, I had another patient who, on her birth plan, had an entire paragraph about the increased maternal mortality for Black women. That's what she spent her time writing about and researching when she was writing her birth plan, rather than thinking about how, we kind of roll our eyes at the playlist, but thinking about the things that would make her birth special and important to her. She was thinking about educating me, the doctor, about her increased risk of dying. And so I approach second stage decisions and really obstetric decision making in a much more nuanced way. I think about how many of the patients that I have regional anesthesia. They are essentially chemically paralyzed. They cannot ultimately, they don't have all their agency. And how does that influence the way that I look at their expertise? How do I look at my power? And how do I view second stage decisions? And of course, I practice evidence-based medicine, but I approach those conversations in a different way than I used to. And I hope by me sharing some of these things with you, it can help you feel a little bit safer in examining some of your own practices. We all, being a part of a harmful system, have perpetuated harm. And so what is it that we can do now to reduce that harm and ultimately to prevent that harm by practicing anti-racism? So this is a lot of information. So where do you start? This is kind of your takeaway slide. You want to acknowledge and recognize intersecting oppressions. So recognize that someone's race, someone's zip code, someone's class, income, and profession, those all intersect and sometimes end up creating a sum that's greater than those parts, and can really create a history and current oppression that we may not be able to see exactly. Really work on humility and vulnerability. This work is about, especially if you are white, especially if you are close to that center of privilege, that center of that wheel of power, is saying, yeah, and being humble about that, and vulnerable in your participation in some of these systems of harm, and in some of your own acts that have perpetuated harm, and giving yourself grace and permission to move forward from that and not dwell in that we kind of sometimes get stuck in that and then pull back. You got to be vulnerable and take that step forward and continue doing the work. Really work to challenge power dynamics when possible, including and especially those in which you hold the power. If you are holding power in a space, step back and ask how that power dynamic may be balanced just a little bit more. It's never going to be completely balanced, but how can you balance it a little bit more? Embrace that lifelong learner. We signed up to a field where a new study comes out and it may completely change the way we approach something, right? I think about ALPS, I think about Arrive, I think about, Magpie, all of these things that have really changed the way that we think about something. We are very used to being lifelong learners and saying like, yep, I was doing that thing and that wasn't right. Embrace that in this place as well. Anti-racism, and as I mentioned, DEI is a journey, it's not a destination. And it's a practice. We will continue to practice it. You want to move through the world with compassion, curiosity, respect, and attention to impact, not attention to intent. My intent is always to be a great doctor to every single person, but that doesn't necessarily mean that my impact is that. And so I need to pay attention to what my impact actually is. And you want to hone and sharpen your skills specifically. When you are feeling frustrated with a system or frustrated with a structure, really step back and start honing your own skills so that you can be a force, one of those little people in that big system. Ultimately, the more of us that hone and sharpen our skills, we will make a system that is more just. These are some excellent books that I have read myself that I personally recommend. So You Want to Talk About Race is a fantastic book by Ijeoma Oluwa. She is a Black woman who wrote this basically for white people to start talking about racism. This is a great book to read with your adult family who maybe is just starting their conversation around race. How to Be an Anti-Racist is a kind of initial look into the framework of anti-racism. Reproductive Justice, an introduction by Loretta Ross and Ricky Solinger is, in my opinion, required reading for OBGYNs and is really, really critical. Killing the Black Body is also a important read, especially for us to understand that history and know more about that history of race and reproduction. And then Medical Bondage is specifically about the origins of American gynecology. It's a short read. It's by Dr. Deidre Cooper Owens and is really impactful and really important for us to understand where it came from. And then Stamped from the Beginning is also fantastic. So I want to thank you very much. This is the wrong email address. I'm not an ACOG anymore. I forgot to change this slide. I'm at societyfp.org. And I really appreciate you showing up with me this morning and listening, and know that we can knowingly strive to be anti-racist. It's like fighting an addiction. Being anti-racist requires persistent self-awareness, constant self-criticism, and regular self-examination. Thank you so much.
Awesome. Thank you so much this morning. I think we have a few minutes for some questions. If anyone has anything, feel free to unmute or put something in the chat.
I have a question.
Please.
So, those books are nice, and, I have several of them. But I think the issue with white people is that white people don't understand Black history and African history, and they don't understand white supremacy history that has told them nothing but lies for the last 400, 500, 600 years. And so that the original people, like in the Middle East, were Black. everybody originated from Africa. Most anthropologists would tell you that the Bible is historically wrong in terms of how it's been presented to the world. And so I just saw a picture of the Ethiopian Bible from the 15th century that showed the true picture of actually who Jesus and Mary were at the time of Christmas. So I don't, I hate, I think that, for me, I think the entire system has to be broken. And if it's not, I think the main thing, and this is, I don't mean to be pessimistic about it, but the worst thing that happened for Black people was when Martin Luther King integrated us into the society. And it may seem crazy, but we had 500 Black hospitals before that happened. Now we have 1 or 2. But we had thriving economies in our communities. And so one of the things that I grew up around all the civil rights leaders. And so one of the biggest mistakes that I reflect on was our integration into the American society, particularly white society, because it hasn't done anything positive in our community. And it's only sucked the blood out of the community. And so I'm trying to work with young women to go to HBCUs and young men, and to actually avoid going to white colleges. I believe that I have never had a Black woman die in my hands in 30 years, 32 years of practice. I don't know what the racial makeup of the Black women that die, but I have not had a Black woman. And I was at Northwestern. We had plenty of people. We had 10,000 births a year when I left. Never lost a Black woman. Nobody's ever, never. So I'm glad that you're doing this and everything, but the system is not set up for the success of Black people. It's set up for the success of white people. And there's no way the Chicago public schools are going to teach a Black young man how to overcome a white man in education. We have 5 of the best high schools in the entire United States of America. Right sitting in the city of Chicago that you all think is so violent. 5 of the best in the entire United States of Chicago. United States of America. They will not, it's a scam. So I applaud what you're doing. I appreciate you giving the lecture. I appreciate you trying and everything like that. But right now we're under a lot of attack. All of this right now that you're seeing with the current situation politically is to figure out how to restrain Black and brown people and women, if they can do it. So, I thank you for it. I appreciate your effort in it. But it's a long haul.
Thank you so much for your lived expertise and for your comments. Any other questions or comments? I want to echo that, yes, this is the long haul, big time. I mean, this is since the very, very beginning, really of human history, but certainly of the United States, and everything we do, every system, every structure is steeped in racism and is steeped in anti-Blackness specifically. And this is a very, very small corner of the world that we have power to potentially work on harm reduction and eventually harm prevention. And so definitely the long haul.
We really appreciate you coming virtually and talking to us this morning. Really great talk. And I'm sure that people are going to reach out. Can we share your email?
Absolutely. Let me put the correct one in the chat, but yes, absolutely.
Awesome. We'll make sure that that gets out to everyone, but thank you again so much for presenting this morning.
Absolutely. Thank you for inviting me. Thank you for having me. And really appreciate you all and your attention.